LUX-Lung 7 was a randomized phase 2 study. It was not a large study, but it asked a very important question. It was the first study really comparing two EGFR inhibitors head-to-head. It was long awaited, and I think we awaited the results of the study with some concern that maybe it would not be powered enough to show meaningful differences. And I think we were quite surprised at the results. It was a very clean design. It was a very pragmatic study comparing two drugs at the usual indicated doses head-to-head, asking an important question. It was fairly inclusive of patients of both types of common mutations, the deletion 19 and the L858R. So it really answered a lot of questions about how do they compare in terms of toxicities in a real-world comparative setting, and how do they compare also with respect to different kinds of mutations we see. Gefitinib has been more or less our go-to first-line drug in Canada prior, and I think in many parts of the world. So it is a very relevant comparison for our Canadian marketplace. Erlotinib tends to have been used more in Canada in the second-line setting in unselected patients. Head-to-head trials should be the main type of trial we see, when really trying to answer a question. It's very difficult to do cross-trial comparisons when you have an important, relevant issue in practice. So I think head-to-head studies are very important and probably not done often enough. I think the major strength of the LUX-Lung 7 trial has to do with its very clean design, a very pragmatic question, and the fact that it's a head-to-head comparison. The LUX-Lung 7 is asking somewhat of a different question than LUX-Lung 3 and 6 because it's really comparing, two EGFR TKIs as opposed to comparison with chemotherapy. But it really helps us, I think, better place the role of afatinib compared to other available agents. With LUX-Lung 3 and 6, we saw clearly, survival benefit. With afatinib, we saw it's better than chemotherapy in patients with relevant mutations. But we're forced to do cross-trial comparisons trying to pick out which EGFR therapy to use. And now we have some direct head-to-head evidence to, again, really comment more on toxicities comparatively and to compare the efficacy more in a head-to-head fashion. I think the main take-home message is that we do confirm efficacy of afatinib. The efficacy, the side effect profile is what we expected it to be. And even though we had expectations, perhaps, that two drugs might be equivalent, frankly, it does confirm that maybe a more potent permanent inhibitor of EGFR may actually achieve better long-term outcomes for our patients on therapy. I think it'll validate our selection more nowadays of using afatinib as a first-line agent until we have the next third-generation drugs down the road. The LUX-Lung 7 results, I think, will again validate our current clinical practice of using afatinib first line. In patients with the L858R mutation as opposed to deletion 19, I think there was some uncertainty. Maybe is chemo better? Is chemo just as good, even though the oral therapies are better tolerated? And I think actually seeing the waterfall plots from LUX-Lung 7 confirmed also that in the L858R patients there's meaningful benefit, fairly rapid benefit, and may help reassure us that we can use these drugs effectively in that population.